Let's say that I'm pregnant. I'm in like the end of the second trimester, beginning of the third, and now I'm starting to realize that my baby needs someone to take care of them after they're born. How do I go about picking a pediatrician?
So it's an important decision. We want parents to have a doctor that they feel comfortable asking questions, especially a new mom that's going to have a lot of questions that maybe she feels silly about or that she should know. We want them to have a pediatrician they feel comfortable with. And picking a pediatrician is a matter of convenience. So is it someone that's nearby that you're going to be able to go
you don't
see?
Have to drive 30 miles to get to them.
When you have an unexpected call from school that says, or daycare, that baby has a fever, needs to go home, maybe you should take them to a doctor. You don't want to have to drive too far to find your pediatrician. Personality is hard to know ahead of time whether that's going to be someone that's going to work for you or not. So looking into location, who's covered by your insurance, and then word of mouth, reviews, friends, things like that are good resources to find out. A lot of parents don't get that far as into picking a pediatrician. There's a lot of things to worry about when an expecting mom is expecting. You got to get a nursery ready, you got to get a diaper bag, you got to get a baby shower, a lot of things to get done, and not always do they pick a pediatrician beforehand. At the hospital, they'll ask who your pediatrician is, who you've selected. And if you say, I don't know yet, there's a system for that. So you'll have a pediatrician assigned to you there in the hospital. And that's not a permanent decision. Those of us that help take care of those patients know that maybe you're from further away than their clinic is, or maybe it's not going to be a good fit. A lot of times it is. And parents think, oh, good, we've met this one. He or she seems really nice.
Introduction.
And they'll say, oh, now we've picked our pediatrician. But it's not something that we know or we think that you're committed to. And so we're happy to point you in the direction of other pediatricians that are maybe closer to your area, or to let you continue looking after you're done at the hospital.
So let's say that I've decided beforehand that I want you to take care of my baby after they're born. Do I need to contact you ahead of time to let you know, or how do you find out that I'd like you to take care of my baby? So
one of the options for choosing a pediatrician is to have an interview with them or a consultation. So you can meet them beforehand. Most pediatricians offer a meet and greet that you can see them a month or two before you're expecting, and just fun. See if that's, this does seem like a good fit, and you can kind of shop around for a pediatrician.
Visit the office, get to know the staff, meet the provider.
Yeah, know what it's like to park there, what it's like to find the area. Does it look kid-friendly, that kind of stuff. And that's one way that the pediatrician can know that they can plan on seeing you in a few months or whenever your due date is. That being said, maybe you are shopping around and they don't know that that's the final decision that you made. When you check into the hospital to have the baby, they'll ask who your pediatrician is. If you tell them Dr. Bowles or Dr. So-and-so is the one that we've selected as our pediatrician, the hospital and the nurses know to put that down in the chart when the baby's born, or if there's issues that they need the pediatrician to be aware of beforehand, they'll contact that pediatrician. One of the issues that does come up is whether that pediatrician has privileges at the hospital that you're delivering at. So we have that happen sometimes down at my hospital where someone has an OB that delivers at Provo, but they actually live in Heber, where they have a pediatrician that they've selected. And in those cases, that doctor in Heber isn't going to be able to come 30, 45 minutes away to round on that baby or to see that baby in the hospital. And so that is, again, another place where an unassigned pediatrician, kind of on a rotating calendar of who takes those babies, is happy to fill in and help take care of the baby while they're in the hospital, and then pass on the baton when it's time for a family to go back to Heber or wherever it is.
You can just make your follow-up appointment with the pediatrician you normally see outside of the hospital.
Yes.
At what time does the pediatrician become involved in the hospital? Like, are they there for delivery, or do they come see the baby later?
So in most cases, when a baby's born healthy, the pediatrician that you've selected, or the one that's been assigned to you in the case of not knowing who your pediatrician is going to be, or if they aren't available at that hospital, is notified the morning after you've had the baby. If it's during business hours, then they might get a call as well. But if it's in the middle of the night, baby's doing well, most pediatricians aren't woken up to know that there's a baby for them to see the next day. Normally, babies are rounded on or examined and seen by the pediatrician once a day after they're born. Normally that happens in the morning before the pediatrician goes off to clinic, but that can be variable as well. Sometimes the baby is born, say, early in the morning, or not too early, say 8 o'clock, and that pediatrician's already started
just barely left
their clinic, but they will get a call saying, oh, there's a baby that has been assigned to you, or that has picked you as the parents have picked you as their pediatrician for you to see when you get a chance. And if that pediatrician has time during lunch or in the afternoon, if they have an open spot, they'll run over to see that baby. So it's not until the next morning that baby's seen. Sometimes that does happen. And the nurses are really our eyes and ears in the hospital that are going to be the person helping answer a lot of parents' questions, talking about feeding early on, how to do different things, and keeping an eye on baby. If any concerns come up earlier, the pediatrician can get involved earlier. But most of the time, they're just stopping in every day to check in, answer questions that haven't been answered already, and to examine the baby to make sure everything's looking good.
So it sounds like pediatricians are aware of what's going on, but may not be there a lot.
Yes, that's a pretty good description. Some babies are sicker than others, and if the delivery is concerning, if there's anything that's concerning from the obstetrician's point of view that they're worried about baby, a pediatrician may be called earlier to come in and help make sure that baby's healthy in the immediate time after delivery. Sometimes the NICU is the one that's involved because the neonatologists and the nurses there are there 24/7 taking care of sicker babies and are available to help with babies that might be sick as well. And so sometimes that job is passed on to the NICU and the pediatrician is alerted after things have stabilized.
Once they've left the NICU and they're feeling better. When pediatricians examine babies in the hospital, what are you looking for?
So after babies are born, there's a lot of changes that go on in their bodies. All of a sudden, their lungs are opening and filled with air, which is how they get oxygen, rather than through the umbilical cord. The heart undergoes some changes to adapt to being outside of mom and into the oxygen-filled world. And so there's things that we want to observe to make sure that they're going correctly. So we listen to the heart, we listen to the lungs to make sure that they sound and are working properly. Most of the time that happens smoothly, and it's one of the miracles of nature that we get to watch all those changes that happen without any input from parents or pediatricians or nurses. But we want to be there and aware if something doesn't go according to plan. Ultrasounds are great and give us a good idea if there's going to be issues for babies to be aware of when they're born.
Like ultrasounds during the pregnancy.
But not always, they don't always catch certain things. And so we are looking to make sure that there's no other surprises on baby's exam. And we do a head-to-toe exam. We're looking at the soft spot and down to the toes, counting, make sure there's all 10. And specific things that we're looking for are to examine closely the heart and the lungs, but everywhere. We look at the eyes, ears, and make sure that everything's working like it should.
What are some common concerns or issues that you see in the hospital when you examine a baby?
So a very common concern that parents have is that baby is not getting enough to eat. We know that for moms that choose to breastfeed, which we encourage, that it takes a few days for mom's breast milk to arrive, to come in, as we sometimes say. And babies are designed for that. They are designed to be born with extra water weight that they pee off, and they lose some weight as they're waiting for milk to come in. But that's normal. We say physiologic. That's the way that babies' bodies are supposed to work. And so that weight loss that some parents can get concerned about in the first few days is actually normal. We do watch it closely because we don't want babies to lose too much weight. We want to make sure that they're not getting dehydrated because feeding's not going as well as it should, although we know that there is some wiggle room for that because it takes time for mom's milk to come in. So we watch what baby's weights closely and make sure that we can help with feeding while you're there in the hospital, and we have nurses and lactation specialists that can help rather than having you have to go to an appointment later after you've been discharged because things aren't going as well.
And moms need lots of confidence before they go home. There's nothing that can cause more anxiety than going home feeling like you're not capable of feeding your baby.
And we know there's still going to be some learning that goes on when you go home, and things change as baby gets older, and as you just have to adjust from being in the nursery to being home. A lot of questions are going to come up, but we want moms to feel confident and supported and know what resources are out there if questions do come up. Another concern that comes up is jaundice. So that's another physiologic thing that babies normally do. Most babies have some jaundice. They're born with extra red blood cells, and those red blood cells are a younger type designed for fetuses, so unborn babies, that are a little more fragile and get broken down as babies are born into an oxygen-rich environment. And one of the byproducts or waste products of those red blood cells is bilirubin, which makes babies look a little yellow or jaundiced. And that's a normal process that we expect to happen. The problem is that bilirubin can be dangerous for the babies if it gets too high too fast. And so that's why we keep a close eye on that as well. And every baby should have a bilirubin checked before they leave the hospital. And then they might need to be checked closer after they've left the hospital, depending on where it is.
Are there risk factors for having jaundice?
So family history is a good predictor. So if parents were babies that needed therapy for jaundice as babies themselves, that can be a predictor. Girls tend to do better than boys. So boys are a little higher risk for jaundice than the girls. And then babies that have blood type incompatibilities between mom and baby, there can be some attacking of mom's antibodies against baby's blood cells. And so if those blood cells are being broken down faster than normal, they can have bilirubin increases faster than normal.
If a baby is born premature, does that also increase their chance?
One of the things, so we know that the bilirubin is going to be released by that process I discussed, but it's also going to be eliminated by the liver. And if the liver is immature, which it usually is for babies, it's not going to process that as well. So that's one of the contributing factors. The more premature the baby is, the more immature that liver is going to process the bilirubin as well. And so that can be another risk factor.
You mentioned one of the first concerns is feeding, but that goes along with jaundice. How do the two affect each other?
So I like to think of bilirubin being excreted through the urine and through poop. And the more the baby is peeing and pooping, the more that they're going to get rid of that bilirubin. And the thing that produces the most urine and the most poop is good feeding. So we know that babies are waiting for mom's milk to come in at the beginning, and that as long as jaundice isn't an issue, we're happy to let that take its course and wait for mom's milk to come in. If jaundice becomes an issue or if weight loss becomes too extreme, then we sometimes will recommend supplementation. So continuing to breastfeed, but adding in some formula feeds as well.
It doesn't mean that you absolutely have to formula feed forever going forward. It's just for that short amount of time.
Yes, usually while we're dealing with the jaundice or waiting for mom's milk to come in. But we want to encourage feeding for babies that are jaundiced to the point that we're either concerned that they might need therapy or that they might need therapy. We want to encourage as much pee and poop as we can to help lower that bilirubin level.
There's no other time in life when you'll care more about pee and poop than you do when you're a parent of a new baby.
Yeah, you'll be paying a lot of attention to how many there are and what color they are and what consistency they are. A lot more than you will in the future.
What concerns are there when it comes to the color of poop? Like, what's normal after a baby's born?
Moms that have been around newborns in the hospital know that, and parents that have been around newborns in the hospital know that meconium, or that black sticky stool that babies have initially, is normal. And eventually, a baby that's, especially one that's breastfed, is going to have yellow, seedy, watery poops. In between black and yellow, you're going to see brown, green, and some variations as it transitions. Babies that are formula fed can have a little thicker or pastier stools than the watery ones that we see with breastfed infants, but they can still have pretty soft and watery ones as well. There's a little more variability.
Are there colors that are concerning?
The colors we are concerned about are the University of Utah colors. So red, it means blood, and so we don't want to see blood in the stool, and that's something that we want to talk to the pediatrician about. Black, after it's transitioned from those initial black ones, is another thing, because broken down blood or digested blood can be black. So we want to check that out if a baby has transitioned to normal looking stools and then has black stools later. So red, black, and then white. So it's very rare, but stools shouldn't be white. It should have color to it. So brown, green, yellow. If it's got zero color, if it's white, then we'd want to talk to your pediatrician as well.
When it comes to the number of stools, is there a number that's concerning? What's normal?
So we expect every baby to poop within that first day, so 24 hours. We want them to have one stool. Sometimes that'll be delayed a little bit, and we have a little wiggle room before we get concerned, but that's the goal that we have.
You want to make sure the track is working,
exactly.
You're getting enough to eat as the days go by.
Same with urination, so we want them to pee once in those first 24 hours with some wiggle room where we might watch. And it's also tough because sometimes the nurses or the parents can miss a wet diaper if it was mixed in with some stool, or if it was just missed for some other reason. Some babies pee right away on the warmer when they've taken over, and that might not get recorded in the computer. But we want to make sure things are working kind of in those first 24 hours. Then things should start to increase as babies starting to get more and more nutrition and more fluid from their feeds. So a general rule of thumb is 1 per day of life. So their first day of life, we want at least 1 stool, at least 1 urination. Day 2, we want about 2. I tend to follow the urination more closely, so that as their kidneys wake up and start working, and as they start getting fluid, they should have 1 for day 1, 2 for day 2, 3 for day 3, 4 for day 4. And after that, babies are going to pee a lot and mostly do 10 or at least 6.
You'll be changing a lot of diapers.
And some babies will pee more than those minimums that we talked about. Some babies on day 3 are going to pee 5 times, and that's fine. But those are kind of the general numbers that we're looking for. Fortunately, there's a lot of good apps that moms can download on their phones that can keep track of this for them, and you can do it on pen and paper if that style suits you better. But it's nice because the pediatrician will ask how many times are they peeing per day, how many times are they pooping per day, and that can give us a good idea of how things are working and how much food they're getting.
Is this something that you're watching just in the first few days of life, or should you continue to track it as the baby gets older?
It's most useful in those first few days, up to 2 weeks, I think, where we're expecting babies to have lost a little bit of weight and then start to gain a little bit more weight. That can be helpful information. After that, some parents find that it's nice to know, like, oh, did they go to the bathroom yesterday? I don't remember. And they can look on their phone and find out. But we're not going to watch it quite as closely after those first few weeks.
If parents choose to have their son circumcised, does that usually happen in the hospital? And if so, at what point? Or is it later in the office?
So it can be either. First off, most pediatricians fall about 50-50 on whether we recommend circumcisions or not. We leave it up to the parents to decide, and that decision is based on a lot of different factors that we leave to the parents. And we're happy to present the risks and benefits to them and help them decide, but we don't want to push them either way. If they've decided to do a circumcision, it can happen either in the hospital or in the office. In the hospital, we wait until they're at least 24 hours old. We want them to have a little time outside before we put them through a circumcision.
A little bit, yeah.
And we also want to make sure that they're doing well. So any significant health concerns, we might postpone the circumcision. The most common ones are jaundice and feeding issues or weight loss in the baby. So babies lose weight naturally at the beginning, but if they've lost more weight than they should, we want to push feeding more. As you can imagine, a baby that's just been circumcised isn't going to be as interested in feeding, and it can set them back a little bit, at least for a half day or a full day. And so if we're focused more on feeding, we may defer or delay the circumcision until later in the office when feeding is going well, weight gain is established, and we don't have any other concerns. Jaundice is another concern that can come up that will delay the circumcision. So same reasoning, a baby that's jaundiced to the point that we're more concerned, we're going to be encouraging feeding so that they can pee and poop more and get rid of that jaundice. And we don't want to set them back by doing a circumcision. Whether it's done in the hospital or in the office, it's the same procedure. It's done with the pediatrician in the same manner. It's just baby's a little older and has had a little more time to establish feeding that we aren't going to set them back as much. But at the same time, there's also benefits to getting the circumcision done with while babies are young and in the hospital to save some trouble for the parents when they're in the office. That can be a long appointment, getting the circumcision done in the office versus being in the nursery where you're already kind of held hostage for a little bit, and we can just get the circumcision done with. So those are some of the more common reasons we'll do one versus the other. Insurance can sometimes be an issue. Most commercial insurances cover circumcision. Medicaid doesn't cover circumcision. And to avoid associated hospital fees, sometimes we'll prefer to do it in the office to make it more affordable for the parents.
Is there a point at which it's too late to circumcise your son? Like maybe you were still kind of making the decision in the hospital and a couple of weeks after. At what point is it too late?
It's a question we get commonly. Some parents that either had a baby that wasn't able to be circumcised in the first few weeks of life, or maybe were having a hard time deciding whether to do it and then decided later. 4 weeks is the typical cutoff that pediatricians will have in the office. Beyond that, it becomes more of a surgery versus a procedure, and we'll refer you to the urologists for that procedure. But unfortunately, then it's hard because it becomes more expensive to see the specialist and an anesthesiologist in the OR, and a lot of times won't be covered as well by insurance. So we try to get it done in those first 4 weeks.
What's next for a baby after discharge from the hospital? Like, when are you going to see the pediatrician again?
So the baby will first see the pediatrician in the office and outside of the hospital about 2 or 3 days on average after being discharged. Some of that depends on how long they were in the hospital. So we know babies that are born vaginally are going to be in the hospital less time than those that are born via C-section, just because moms need a little more time to recover after having the surgery versus the vaginal delivery. Babies that have been monitored in the hospital after C-section for 4 days don't need to be seen quite as soon as those that were only in the hospital for a day or two. But in general, between 2 and 4 days. And the pediatrician, depending on how feeding is going, whether there are jaundice concerns or any other concerns, will help tell you, well, let's see, maybe in 1 day or 2 days versus the longer period. Weekends can get a little tough because not every pediatrician's office is open during the weekend. And if you're discharged on a Thursday, Fridays may be too soon, Mondays may be a little too late, and you and your pediatrician will have to talk and decide what's best for the baby.
So it sounds like it's a little circumstantial, and the pediatrician will communicate that to you when you go home.
Yep.
Call me and make an appointment for
and most pediatricians will give you instructions on how to make that appointment, where to make that appointment, and when to make that appointment. But in general, that newborn visit is within the first few days, and then the babies fall on the well child schedule, which is at 2 weeks, 2 months, 4 months, and so on. But that first one happens within just a few days.
And having been a new mom myself, I remember I had a ton of questions. I felt like I had to read every single piece of paper that was handed to me in the hospital, even being a nurse, and that I just had to absorb all this information to feel even a little bit confident to go home and care for the baby on my own. And then even when I got home, there were tons of questions. And so I just wanted to throw out there too that I think it's good advice for moms to write down all their non-urgent questions so that when they have a chance to see the pediatrician again, you can pull that list out and be like, okay, these are all the things I've been thinking about, because inevitably you'll get home and think to yourself, I forgot to ask about whatever it was.
Yeah, it's definitely good practice to do that. Keeping track of urine, stool, and writing down those questions are good practice, because the pediatrician is going to ask about all of those, and we want to answer the questions that come up after you've gone home.
Good tip. And is there anything else that they should keep track of?
The paperwork that is sent home with you is substantial, and some of it is more important than others. One of the things that the hospital will tell you about is the newborn screen. So there'll be an envelope with a pink piece of paper that you're supposed to take back to your pediatrician. That's usually not done until 2-week visits, and so it's good to remember it and have it with you when you see the pediatrician, but know that it might not get taken care of until the 2-week visit.
Are there any screenings that are done during the hospital, and what screenings are done later in the office for a baby?
So the screenings that are done for the baby in the hospital usually start at about 24 hours after they've turned that first day after being born. And they include pulse oxygen, so a pulse oximeter that's placed on the baby's hand and feet to make sure that oxygen and blood are getting where they're supposed to be. That's kind of a quick check to see that their heart is working like it should be. We also poke their heel and get some blood that's sent to the state lab to check for more rare genetic diseases that can be acted upon earlier rather than waiting until they have symptoms later. And so those are sent to the lab or to the state lab. We don't find out those results for a few weeks. If it's something that it pops positive, it'll happen quickly, and the state lab will hunt us down to make sure that we take care of it. But a lot of times it's normal because these are rare diseases, and we don't find out that it's normal for a few weeks. So don't panic if you haven't heard anything about that.
So you'd follow up with the results in the pediatrician's visits
you won't find
a couple
out about,
weeks down the road.
Yeah, you won't find out about that
normal.
in the nursery. Okay. We also check for bilirubin. So at 24 hours or a little later than that, every baby should have a bilirubin tested to see if it's getting too high, too fast, and when we need to check it again, if at all. We do a hearing screen, so babies will have their hearing tested. Not every baby passes that right away, and that's not a reason to panic. Sometimes there's still fluid from the delivery process and from being inside that amniotic sac for such a long time that it takes time to clear. And so the hearing screen will be repeated later to make sure that that's had time to clear and the babies pass. If they don't pass in the hospital, we check again in the outpatient setting to make sure that they do have normal hearing, or if there's anything that we need to do for that.
Well, Dr. Bowles, that information is so helpful. Even if you've had a baby before, maybe you're not aware of all the things that happen behind the scenes, or you just didn't know why things were done the way they were. So thank you so much for spending time with us today. Where can people find you?
So I work in Provo. I work at the Utah Valley Clinic, which is attached to Utah Valley Hospital in Provo. And I work for Intermountain. So any of those searches will lead you to me, or just search for Dr. Austin Bowles.
Awesome. Thank you so much for being with us today again. And if you guys have questions in the future for me, feel free to ask them on our Intermountain Moms Facebook and Instagram pages, and recommend us to your friends and family too.